Hello everyone, thank you for coming. Welcome to NADO's 38th Annual Conference. We will be starting in about one. Hello everyone, thank you for coming. Welcome to NADO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Norm Thurston, NADO's Executive Director. Norm, the stage is yours.
Thank you, Erica. We're so excited to have you here for our closing plenary today. It's been a fabulous conference and we've all learned a lot. This session is entitled Improving the Value of Healthcare with Innovative Data and Analytics. The session was organized by Kathy Hines and Betty Harney, both from CHIA in Massachusetts. Betty will be joining me on stage momentarily as our moderator. Charles, can you bring Betty on stage? Hey, Betty, how are you doing?
Hello, greetings from Boston in CHIA.
Yay. All right, well, I'm going to turn the stage over to you and we'll get started.
Perfect. Hello, everyone. As I said, greetings from Boston. We had some snow showers this morning, so we're really feeling the seasons. We're going to learn about innovations in this last session. So I just want to thank NADO for this opportunity to moderate, and I'd also like to thank Kathy Hines for helping to organize this session. The first innovation we're going to talk about is probabilistic matching. And we have Cindy McElhaney from Comagin Health and Greg Sutliff from Project Access Now. So Norm, Charles, I think we're ready to roll the first presentation.
Hi there, everyone. My name is Cindy McElhaney. I am from Comagin Health. I am co-presenting today with Greg Sutliff from Project Access Now. They will introduce themselves in a few moments when we get to their slides. We are going to be talking, the title of our session is Demonstrating Programmatic Value Using Probabilistic Matching to Combine Datasets for ROI Analysis, which is a mouthful. I'm just going to go real quickly through a few slides about Comagin Health to tell you who we are. We are a healthcare consulting company that basically a nonprofit that together with our partners, we work to improve health and create a better healthcare system so that people in communities will flourish. These next two slides just show our footprint. We are a national company. We have offices across the country. And here is basically where we do our work. These are the present states where we have activity going on in some form or another. Our company is divided up into 4 major divisions that do different types of work, including quality improvement work, care management work. We have a research evaluation arm, and I work for the data solutions team, which basically does all sorts of things data related, including analytics, HIE consulting, and we work with some very large data sets. And now I'm going to turn it over to Greg to introduce themselves.
Hi everyone, I'm Greg Sutliff. I'm the Vice President of Finance at Project Access Now, and we are a nonprofit organization based in Portland, Oregon, and we serve the Tri-County area around Portland primarily. And we have a number of programs that attempt to address health needs in our region, largely for folks who don't have access to various health coverages, and we connect people with Medicaid, helping them to apply. We connect people with donated medical care if they are not eligible for Medicaid and don't make enough money to be able to afford insurance. We also help connect people to various health-related services and goods like taxi rides to and from hospital and doctor's appointments, rental assistance for folks who are at risk of losing their housing and who are recovering from medical conditions and treatments, and gym memberships and things like that. But for the purposes of our presentation today, the main interest is our premium assistance program, which pays insurance premiums for folks who make too much to qualify for Medicaid, but for whom marketplace coverage premiums still are not affordable. So that program helps to pay, and in fact pays entirely their premiums. If you go to the next slide, okay. So the program receives about $1 million in funding each year from the hospital systems in the area. It's been around for several years now, and the funding pays for the premiums for folks who are under 300% of the federal poverty level, and the amount that's given to us is leveraged in that we are just paying the amount of the premium left over after the tax credit that folks receive from the marketplace is applied. In addition to that, all of the hospital systems that are paying into the program agree to waive all the out-of-pocket costs for all of our clients enrolled in the program. That's my last slide for now, so I will pass it back to Cindy.
Just going to talk real briefly about our the work we did for this. So we at Comagine Health, we have an APCD in Oregon that has all of the large health plans contributing to data. So we basically linked the patients and families that were enrolled in the Premium Assistance Program with Project Access Now to our ODC claims. The major part of the analysis was a return on investment analysis that we did for the Premium Assistance Program. Basically, we wanted to see what kind of return these 5 health systems were having. They're paying these premiums. How much money are they saving? That was the big piece. Then we had 2 other additional pieces. One was to look at member out-of-pockets for a pharmacy bridge program, and then we provided some additional drill down into costs according to patient characteristics. This was all for private reporting to Project Access Now leadership so that they could use this information for their discussions about funding with the health systems. So the most geeky technical part of the work we did is we had a probabilistic matching algorithm that we basically piloted with this program to basically match the patient information we got from Project Access Now with the eligibility and claims information we had in the APCD. We used an R package called FastLink. It's open source software. It's out there for everybody to look at. And it implements some methods that are described in a very technical paper that I have linked here in case you want to look at that later. So the input variables to the matching algorithm we used were name, address, gender, and birth date. And we chose a probability threshold of 0.85 with the final piece of the analysis. We did a lot of experimentation with different probability thresholds to see what would get us the best match, and this is what we settled on. We ended up with a pretty good matching rate for the subscribers that we had in the data. We had about a 98% match. The dependents were lower, around 88%, and that was mostly due to missing data on gender and birth date that we may have had. The other pieces of the work that we had to do is we built a patient master list that basically had the enrollment dates that they had for Project Access Now. Because we were working with the APCD, we didn't want to pull in any claims costs that had been paid through other insurers or other things that the member might have been enrolled in. And then the other thing was the premium information we received from Project Access Now was transactional, which means the data was captured when the premium was paid. So we had to do some data transformation to accurately calculate the amount of premium that was being paid for each month. Our findings, it was pretty interesting work, and the big one was on the Premium Assistance Program. Participating health plans received almost 2 times their contribution as claims payments. So how we defined this is we looked at the inpatient and emergency department visits that were paid by the health plans as a proxy for what the health systems would have paid as charity care. And we found that that amount of money was almost 2 times their contribution, which is a pretty good return on investment. There's probably some other savings that came with this program. You would think that once a person has insurance, they have access to care, they have access to PCPs and pharmacy and all of those other things that keep them healthier. And there was probably some cost avoidance from that, but that was outside the scope of this analysis. The pharmacy bridge analysis. So Project Access Now provided assistance for pharmacy copays. And what this analysis did for Project Access Now, they knew how much they were paying to assist their members, but they did not know how much their members were paying out of pocket that they weren't aware of. And we found that they were providing assistance for 10% of the members with prescriptions only covering about 6% of the copay costs. And so there were discussion about expanding the program and finding funding to help more people with those pharmacy costs. We provided a cost drill down on the return on investment by these different age bands, including the presence of chronic conditions. We found that 53% of the members had a chronic condition, 32% had at least 2 or more. And now I'm going to turn it back over to Greg on how this information was leveraged.
Thanks, Cindy. So it's obviously extremely powerful for a nonprofit organization to be able to clearly articulate to its funding partners that not only are we offering an opportunity to them to benefit the community in Portland and advance health in our region, which is part of the mission of the hospitals that we're partnering with, but simultaneously they receive a 2-to-1 return on investment for doing so, which is a hard ROI to beat anywhere. So it's been extremely powerful for us to have this data, and we're very thankful to CoMagin for doing the work with us to come to it. As a consequence of this, we've seen a significant increase in the amount of funding that the local hospital systems have been investing in Project Access Now's programs over the past year to 2 years. So we have seen only positive results and continue to be able to use this information in conversations with partners. So I'll kick it back to you, Cindy.
Right, I'm just going to wrap up really quickly with lessons learned. The first lesson learned is always be ready and willing to pivot. What we delivered in the end to Project Access Now looked very different from what we had agreed to provide at the beginning of the project. And that was just responding to what we had in the data and what we thought would be helpful for them to answer their questions. Be specific about data requirements from partners. I think we would have had to do a lot less data transformation and data work if upfront we had laid out and worked with them to decide exactly what they needed to send us to do our work. And then the last lesson learned is know when to let go. You're not going to get it perfect, and you need to know when you have enough to provide your partners with the answer they need. And that's all.
Wow, congratulations. That really presents as such a success story from the beginning, and so many facets of that project are successful. I just wrote down like your match rates on the subscribers at 98% and on the dependents 88%, and you almost were apologizing for the 88%. I think that that's a huge accomplishment. So congratulations. And then further, when you proved out what the impact and your findings were amazing. So I could gush about this analysis and this innovation, but I want to just see if other people want to chime in with their questions. I have a question, but let me just see what folks are thinking about here. Well, let me ask you one of mine. Talk to us a little more about the probabilistic matching algorithm. Were there areas that didn't work as well as expected?
Sorry, I was on mute. Sorry about that. So one of the things that was kind of a luxury with this project is the number of members enrolled in Project Access Now was relatively small compared to a lot of other projects. So we were able to really vet the algorithm and its output really well. And there were just a couple of areas that I thought were interesting where it didn't work very well. One of them is it seems to fail when names are hyphenated. So if in one data set the name was hyphenated and the data was not hyphenated in another data set, it didn't do a very good job of matching it. The other, and we've been talking a lot in this conference about health equity and data disparity, and this is just one of the things that I noticed is certain name types, it didn't match well. It had trouble. The R package had trouble with Asian names, frankly, especially in cases like Vietnamese names where the surname precedes the first name. It just didn't seem to, when they were flipped in the different data sets. And I think that's more of a data collection kind of issue, that we're not always sensitive to those nuances in how we collect the data and what we mean when we say enter your first name and enter your last name here. So yeah, that was interesting.
So just to kind of level set, at least it raises a question in my mind, in that you're talking about what I would say about data quality issues. But how many people are we talking about? Like, how many names of distinct individuals are we trying to align and match, just so the audience has a feel of the scope of the project?
Yeah, I think at the time, I think we had about 1,500 people. And like I said, it was a pilot project to see how well this tool worked for us. I believe our research team has used it since then and still gets a pretty good successful match rate on it. So on larger data sets.
Okay. I'm hearing that there's a lot of questions in the chat. And I am looking for those questions. Maybe Charles or Noah could.
I see one on the screen. It says, "Did you normalize the name and address before matching?" No, we didn't. Not for this particular project. I think it would be worth doing that if you were working with a much larger data set. Run it through some address normalizers, and that type of thing would be a really good thing to do.
Okay, I agree. Because as you already have highlighted, it's all about the format of the name, and how well it's going to match the first name, last name. Did you have first name, last name separate or together?
They were in separate fields, and so was middle initial, and there was a suffix also, some juniors in there in the match.
Okay. So I can't see the other question, so.
The next question, I can see it on the bottom of my screen. Asked to post the link for the matching software. I will do that when we're done here. And the address elements that we used, I believe we had the street address, city, state, zip code. I can't remember if we had a second address, where usually the suite is captured. We may have had that there.
Okay.
So Beth asked, what was your counterfactual comparison group and how did you calculate ROI? So we didn't really have a comparison group for this. This was out of the scope of the project. And the ROI, I've been getting a lot of questions. It was a very high level pass at a return on investment. The assumption is that the inpatient costs and the ED visit costs for these members would have been paid as charity care by these health systems if they had not had insurance. And so we basically, Greg supplied what the health systems had contributed. I supplied their inpatient and ED visit costs. And when I calculated the cost, I did with basically a vertical cost where it wasn't just the facility costs. I included oh, actually, no, I did include just the facility costs because that's what the hospital systems would have been paying. And it was just a really simple comparison of what the health insurers paid for these services versus what the health systems contributed.
Okay, thank you. So I think we're going to just move on to the second presentation, and folks, hold your questions until the end. The second presentation is about more innovation. It's decision-making tools with cost information using analytics to improve patient and provider experiences by Robin Gelberd at Fair Health.
Thank you for joining today's session. My name is Robin Gelberd, and I am the president of Fair Health. I look forward to sharing with you Fair Health's groundbreaking work in the realm of shared decision-making. For those less familiar with Fair Health, we are a national, independent nonprofit established to bring fairness and integrity to health insurance information. We meet that goal by having the largest collection of private insurance claims in the country and by being prudent stewards of that data. We now have over 42 billion private insurance claims and receive over 2 billion new claims each year. The data are received voluntarily, typically monthly, from over 70 national and regional payers and third-party administrators, and reflect both self-insured and fully insured covered lives. The claims also reflect both bill charges and in-network negotiated amounts, among other key elements. Apart from our commercial data collection, we are certified by CMS as a national qualified entity, and thus we have been entrusted with the entire collection of Parts A, B, and D of the Medicare dataset for all 50 states. Currently, that collection accounts for over 45 billion Medicare claims, which are housed separately from our commercial data. Medicare Advantage data are housed with our commercial collection. Now let's turn to shared decision-making, or SDM. SDM is the process by which patients, their caregivers, and healthcare providers collaboratively decide on tests, treatment, and care based on clinical evidence, balancing risks and outcomes with patient preferences and values. It's typically facilitated by decision aids. Until Fair Health entered the SDM space, such tools lacked a cost component. We heard from SDM experts around the country that when they offered clinical decision aids showing various treatment options, often the next question from consumers would be, what would this choice cost compared to the other choices? Fair Health now integrates cost estimates drawn from our rich claims data collection with certified decision aids to provide that missing puzzle piece that has been sought by patients and their families. Fair Health has advanced several groundbreaking SDM initiatives through generous grant funding from multiple organizations. In 2019, we received our first grant in support of SDM from the New York Community Trust. With that grant, Fair Health created and launched an SDM section on our consumer website, Fair Health Consumer, with 3 decision aids, which include both clinical and cost information for scenarios that are really common among seriously ill patients. Our work with the trust caught the attention of other funders. At the invitation of one such funder, the Fan Fox and Leslie R. Samuels Foundation, Fair Health undertook a separate program to promote SDM among providers by launching a provider-centered website called Fair Health Provider. Fair Health Provider offers our decision aids, resources, and educational content to support providers in having SDM discussions with their patients and the patient's caregivers. Next, Fair Health received a grant from the New York Health Foundation in support of an SDM program geared for minority patients. This project involved the development and launch of 4 new decision aids with treatment options and related costs for conditions pertinent to minority patients. Our most recent SDM projects have been funded by the John A. Hartford Foundation. Our first initiative funded by the John A. Hartford Foundation constituted a pilot project focused on 4 geographic areas and included the development and dissemination of tools relevant to conditions that affect older patients, together with educational content and external resources. The second initiative, now underway, builds upon the earlier pilot project against a national canvas and adds, among other new features, the goal of implementing the tools at the point of care in collaboration with 4 age-friendly health systems nationwide. On this slide, we see the tools developed in connection with each of these various grant-funded initiatives. In the following slides, we'll take a closer look at some of these resources. As previously mentioned, Fair Health houses its SDM tools on its award-winning free consumer website, Fair Health Consumer, which helps consumers understand their health benefits, plan for their healthcare costs, and gain heightened levels of health insurance literacy. The site is available in both English and Spanish. Here we see the landing page of the SDM section of Fair Health Consumer, which provides an overview of SDM. The top navigation bar of the site prominently features our SDM platform. On the right side of the page, you can find our current array of decision aids. Here's a closer look at one of our SDM tools. The decision aid for slow-growing prostate cancer was developed for our project to promote SDM among minority communities. Before we get to the decision aid itself, we see here the topic page for the condition. It links to external resources and includes a printable checklist with questions that patients and caregivers can ask providers to help guide decision-making. This decision aid features a series of questions related to each of the clinical pathways for slow-growing prostate cancer: watch and wait, monitor with tests, radiation treatment, radiation implants, and surgery. The question posed in this screenshot is, what does the option involve? The answer includes descriptions of each treatment option in easy-to-understand language. These are the other guiding questions that users can review before selecting a treatment option and viewing the associated costs. These questions can serve as the basis for the SDM discussions between patients, caregivers, and providers. If the patient chooses to do so, they can select a treatment option and go to the next page to view the costs. The cost information offers a detailed breakdown of the treatment option's relevant services, as well as a comparison of in-network costs in red and out-of-network costs in blue in the patient's geographic area. In this case, the option selected was watch and wait. As mentioned, we offer checklists that include questions or considerations to help patients and family caregivers advance the SDM process. Here are screenshots of both patient-oriented and caregiver-oriented SDM checklists with suggested questions to ask. Another resource on Fair Health Consumer is our homegrown educational curriculum, FH Insurance Basics, which covers a wide range of topics pertaining to health insurance and navigating the healthcare system. We have over 40 articles and counting on topics ranging from understanding your medical bill to the benefits of health insurance wellness programs. As you can see, we have 3 articles dedicated to SDM. Consumers can also access the Fair Health Quality Toolkit, which offers information about characteristics and measures that may point to the quality of healthcare providers and help guide patients in the selection of a provider or facility. Fair Health Consumer also provides links to external governmental and nonprofit resources that assist consumers with their healthcare journey and health insurance, including patient disease organizations and support groups for family caregivers, among others. Here, we are looking at the dedicated older adult section of Fair Health Consumer, which was added to our site as part of the initiative funded by the John A. Harford Foundation, focused on SDM among older adults. It can also be accessed via the top ribbon of the consumer website and provides a range of relevant educational content, resources, and tools, including our SDM tools, checklists for SDM, and total treatment cost scenarios, among other key features. The older adults page of Fair Health Consumer also features a section with links to external resources specific to older adults. In addition, it includes a financial health literacy component for older adults to combat against the growing issue of financial toxicity. Financial toxicity is the financial, emotional, and mental burden patients experience from the medical costs, which can lead to diminished access to care and reduced quality of life. In addition to helping advance financial health literacy among older patients and their caregivers through SDM tools, we also offer educational information on understanding and managing healthcare costs, as seen here. Our provider-oriented educational website, Fair Health Provider, offers guidance on integrating SDM in discussions with patients and their caregivers. Providers can access the decision aids from this free website and use it to direct their patients to the SDM resources on our consumer site. The provider site includes an introductory explanation and overview of SDM for providers less familiar with this paradigm of care, as well as SDM tools and resources. As part of our SDM initiatives, Fair Health conducts program evaluations to understand the impact and utility of our tools. To conduct these evaluations, we use both qualitative and quantitative methods, including website usage analytics, social media engagement analytics, surveys, focus groups, and qualitative feedback sessions with providers and relevant experts. Overwhelmingly, we have observed that SDM tools are useful and valuable for providers and patients alike, with stakeholder feedback revealing that cost information in SDM conversations enhance their decision-making. If you would like to read these program evaluations, you can access them on our website at the link included on this site. Thank you, and I'm happy to address any questions you may.
Wow, thank you, Robin. That is a wealth of information, and it's such a rich tool that you just shared in such a short period of time. Thank you so much. I have an initial question. Are there ways that you're going to raise awareness of this tool as helping with the paradigm of care?
Thank you for that, Betty. So as with everything we do at Fair Health, we never want it to be like a tree that falls in the forest that nobody hears. So we always look to share the work we're doing, and we do that through various channels, through conferences like this. We offer webinars, we have articles written about it. We issue different publications about it as well. We reach out to healthcare institutions and let those stakeholders know, as well as patient disease advocacy organizations. And it's clear that SDM is sort of permeating sort of the healthcare permafrost, if you will, because we're finding tremendous interest on the part of age-friendly health systems to partner with us to see these resources and tools at the point of care, which is our next sort of foray into shared decision-making through our latest grant.
Wow. Yeah, that's an excellent answer. Thank you. Because I think it's a great tool, and the key is making providers aware that this is out there. You showed some of the publications you issued associated with your prior work. Do you plan to publish these findings in the near future?
Oh, absolutely. So one of the things that Fair Health does, we sort of operate on a macro and a micro level. On that micro level, we want to help John Doe or Ann Smith get the most information, or their caregivers on behalf of them, to learn about a condition or procedure they're considering, and help them with those discussions with the actual provider. On the macro level, we really like to gather information, qualitative and quantitative, gather that rich data. And in this instance, at the point of care, that data will be quite rich to see what the utility is of these resources. How does it impact decision-making? How does it enrich the conversations between the providers and the patients? We will compile that, synthesize it, and definitely publicize it and make it available at no cost on our website and through other channels.
How do you, like you talk about collecting more data, how will you, what will the mechanism be for collecting that data?
Well, to date, where our resources have been housed on our website and on the provider website, we have engaged different focus groups and have sent out different surveys through the assistance also of our expert provider advisory group, and got that feedback to disseminate in the reports that were shown on the slide. In the instance at the point of care, we will be developing an instrument with our institutional partners about how to elicit information. Did these resources cause you to make a different decision, for example, than you originally intended when you came in? How much, if at all, was cost a factor? How, what else in that decision aid really turned you from one direction to another? Did that lower your stress level in interacting with the healthcare system and make you feel like a more empowered consumer and patient as you navigate these sort of Byzantine halls of the healthcare system itself? So we'll learn quite a bit. And we'll also know from the institutions what procedures happen more frequently attached to a specific diagnosis versus another procedure.
Okay. Wow. Yeah, the feedback loop seems really important. I'm just going to look over at the questions. I have one from Martha Mayer. Is the use of this tool billable so that we would be able to see utilization in the Colorado APCD?
Well, what would be obviously visible to the APCD would be whatever is reflected on the claim form. And what would be reflected on the claim form is what procedure was actually elected. But that raises a very interesting question, because one of the things we hear back from providers is we see the value of these conversations, but these conversations take time. Will there be reimbursement for these conversations so that we can fit them into our workday? And that's why what we do on the macro level becomes so important, because as policymakers learn about the value of these resources, there may be an inclination to make certain decisions about what type of conversations should be reimbursed and captured so that it can be advanced between the patient and the provider.
And they would be worth paying for, because in the long run, it saves money if you can have these conversations up front about the cost and about the options. Okay. So I'm just looking if there are any other questions. I don't see any other. So I'm going to propose that we move on to our third presentation, but Robin, that was wonderful. So our third presentation is, Chia, Stephanie Williams, and Brian Beeman. Thank you guys for waiting so patiently to this point, and we are going to learn a lot about your innovation, which is dashboards with emergency department data. Please share with us.
Hello, everyone. I'm Stephanie Williams. I'm a senior research analyst at the Center for Health Information and Analysis, or CHIA for short. And with me is Brian Beeman, associate manager at CHIA. CHIA's mission as a state agency of Massachusetts is to collect healthcare information, to responsibly steward sensitive and confidential data, and to objectively report reliable and meaningful information about the quality, affordability, utilization, access, and outcomes of the Massachusetts healthcare system. As part of our mission, CHIA is responsible for collecting and maintaining the Massachusetts Acute Care Hospital case mix databases. This year, CHIA began reporting on emergency department data and dashboards to get timely and accessible information on ED capacity and congestion in the hands of interest holders. In our session today, we are going to talk through our experiences and lessons learned in evaluating quality for the recurring releases of our dashboard. We highlight some of the measures that we review to check data quickly so we can get data available as soon as possible. First, we'll provide a brief background on our Massachusetts Acute Care Hospital case mix databases, the ED data used in our dashboard, and our length of stay measure. Next, we will describe some of the limitations of our length of stay measure. Following that, we'll describe the data challenges we discovered while working with our length of stay measure. Then we'll discuss how we handled challenging data in our reporting. And then we'll wrap it up with discussing the significance of ensuring the quality of our data. Now I'll hand it over to Brian to provide some background on our case mix databases and the data used in our ED dashboard.
Thanks, Stephanie. As mentioned, CHIA, as an agency of the Commonwealth of Massachusetts, is responsible for collecting and maintaining the acute care hospital case mix databases. The case mix data includes detailed information submitted from all acute care hospitals in Massachusetts, including patient demographics, admission and discharge information, diagnostic and procedural coding, provider details, and detailed charge information. The case mix data includes detailed information on different types of hospital visits, including inpatient discharges, which are found in the hospital inpatient discharge database, outpatient observation visits, which are found in the outpatient observation database, and emergency department visits, which are found in the emergency department database. CHIA's case mix data goes through a process of data intake and processing, as well as checks for quality assurance. Acute care hospitals submit data to CHIA quarterly. As one of the primary users of the data, we work closely with our data operations team to make sure issues are identified and addressed to improve quality with future releases. CHIA uses the following data submission flow when classifying hospital visits into the Massachusetts case mix databases. It is important to note that this flowchart does not reflect the pathway of care a patient may experience in the hospital, but rather how acute care hospital records are classified. If a patient was admitted to the inpatient setting, they'll be found in the HIDD. If a patient was sent to observation but not admitted, they'll be found in the OOD. And if a patient was seen in the emergency room but not admitted or observed, then they will be in the EDD. Today, we are focusing on the EDD data consisting of ED visits resulting in neither an inpatient admission nor observation, otherwise referred to as treat and release visits. The EDD dashboards use treat and release data only, and today we'll be focusing on federal fiscal years 2019 through 2022. To provide interest holders and policymakers with timely and accessible information on hospital capacity and ED congestion, CHIA developed an interactive ED dashboard building upon an innovative reporting series providing analyses on patterns and trends of acute care hospital services from CHIA's case mix databases. This dashboard provides insights on statewide ED utilization, utilization by zip code, utilization by hospital, visit characteristics, diagnoses, behavioral health, and COVID-19 on a quarterly basis. As a key measure of ED performance and hospital capacity, the length of stay is also tracked. The length of stay is calculated for each visit by subtracting the date and time of the ED visit arrival from the date and time of the ED visit departure. Several data quality challenges exist in analyzing this length of stay data. 3.2% of our data on length of stay requires careful consideration, meaning that there were data challenges significantly impacting the average length of stay that needed to be addressed. There are a couple of limitations in our data analyses using the ED length of stay data. First, our data does not include wait times. The ED registration times are based on the time that a patient was triaged. Secondly, this analysis in particular looks at treat and release ED visits, so we do not include ED visit information from inpatient admission or observation records. These limitations highlight the challenges in assessing a patient's continuum of care in the pre-acute care period, during the acute care visit, as well as post-acute care settings, and highlights the difficulty of getting the full picture of hospital throughput and the impact of the ED length of stay. Now I'll hand it back to Stephanie to discuss the data challenges we encountered.
Thank you, Brian. First, we discovered that 2 hospitals reported identical arrival and departure times for all their visits for years 2020 through 2022. Given our measure of length of stay, where we subtract the arrival time from the departure time of the visit, this resulted in a length of stay of 0 for all hospital visits from these 2 hospitals over the 3-year period. Between federal fiscal year 2019 and 2022, most hospitals had less than 0.1% of visits with 0 length of stay. Including the length of stay for these visits would have decreased the average length of stay in our reporting during the 3-year period. Next, during Q3 of 2019, there were 3 hospitals that reported nearly all of their ED visits as having a departure time set to 0, which represents midnight in our data. Between federal fiscal year 2019 and 2022, most hospitals had less than 0.05% of visits with midnight departure times. With our calculation of length of stay, including these visits would have increased the average length of stay during this data quarter. In addition to these 2 challenges, there were also a small amount of visits missing arrival and departure time. There were also a small number of visits with a very long length of stay, some of several months or years, inflating the average length of stay for a few quarters of data. Careful investigation at the hospital quarter level led us to exclude data when there were consistent patterns of irregular reporting in a hospital quarter. Length of stay data were excluded when hospitals had 100% of visits with a length of stay of 0 hours, or when the hospital had nearly all registration times as midnight. In contrast, most ED visits with very long length of stay were not excluded because many of these records had principal diagnoses associated with longer length of stay. A few visits and 3 hospital months were excluded due to abnormally inflated lengths of stay that drove up the average. Similarly, with missing data, CHIA decided to leave the data as missing instead of imputing arrival or departure times due to the small percent of missing data. In addition to applying exclusion criteria to our data processing, CHIA presents ED dashboard data on a quarterly rather than monthly basis to lessen the effects of a few very long or short lengths of stay. This chart shows the trends in average length of stay with the invalid data included and excluded, the orange line with the invalid data included, and the blue line with the invalid data removed. The increase in length of stay in Q3 of federal fiscal year 2019 is the result of visits with a high percentage of midnight registration times. The lower length of stay for most quarters before removal of invalid data between federal fiscal years 2020 through 2022 was a result of the hospitals that reported 0 length of stay for all their visits during those 3 years. Choosing a method to account for data challenges requires careful investigation. Given the importance of ED length of stay as a key capacity and performance metric, addressing data issues and ensuring reporting quality is critical to avoid under or overestimating values. We are showing the challenges we've encountered in working with ED length of stay data and share some of the best practices used in CHIA data processing, analysis, and reporting that could be useful for other states in addressing similar data issues and challenges. Given that ED capacity and boarding is currently a major topic of interest, it's crucial to ensure the best quality of data before showcasing trends using length of stay. Chia will continue to carefully investigate data before reporting. And now we'll move into answering questions. If you have any further questions or comments, here's our contact information. Thank you so much for listening.
Wow, that was great. As someone who works in data quality, I just appreciate and am grateful for your thorough analysis of the length of stay and your the way that you documented, shared it with the audience here, and then showed your remediation. One question that raised in my mind, maybe because I'm here at CHIA, is, and I don't know if you mentioned it, but what about resubmission? So you had these findings that certain hospitals either reported all midnight, and you knew that that was probably bogus. So did we ask for resubmissions, or is that something that you can speak to?
Yeah, sometimes these issues are things that we are finding sometimes years after the fact. So I think specifically the midnight registration was an issue in 2018 and one quarter of 2019, our federal fiscal year. And we were not identifying it until we were like getting more into using the data ourselves in like 2 years later. And so then at that point, that was like kind of past like the resubmission point. So it was one of those things we had to consider. It's a limitation of getting that data resubmitted. So then how do we then therefore handle that data since we are not able to get it resubmitted? But so if we identify the issues more readily, we can identify those and have the hospitals resubmit that data to us.
Thank you. Yeah, I appreciate the dashboards, your innovative way of really looking at the data and then either including or excluding and highlighting the fact that that is so important to know your data before you report out on trends, especially, and you showed the difference in trend, which was great. So I'm gonna look to see what the audience is saying. Oh, so Norm is giving some feedback, very interesting presentation. I have a question for you too, another question. What about, talk to us about the topic of imputing invalid data. Did you consider that or not?
Yeah, that was something we considered at first, potentially imputing, especially if it was like one quarter of data within a year, imputing the average length of stay of the hospital for the rest of the year, since it was given that given time period. But given that it would be imputing an entire quarter of hospital's quarter of data, you're looking at hundreds, potentially thousands of like ED records. You're doing a large scale imputation on whole sets of data for like entire months, where you have to consider not just the hospital, to consider the hospital, the patients, the hospital's case mix, the diagnoses, the patient demographics, whether if you decide to impute. And I think the data was so missing that I don't think we felt comfortable in imputing at that large of a scale at entire hospital quarters of data.
So again, I appreciate the thoughtfulness behind that. Sylvia has a question. Was there any association between missing departure time and diagnosis departure status? For example, a SUD patient who left against medical advice. And maybe that's not something that you looked at, but that you could look at, but I think she's wondering.
Probably related to hospital specific.
Yeah, we didn't specifically look at departure time, although that is a great suggestion, and we can certainly look into that. Departure time isn't a variable that we typically have a ton of confidence in, unfortunately. But
it's departure status that she's talking about, but okay.
So, it's like
but departure status, that's what I meant. Thank you. But yeah, quality issues like this are usually not related to like a specific hospital or characteristic, but we do notice inconsistency in these kinds of inconsistencies more at the hospital quarter level. So that's why we think it's very important to perform these quality checks.
Okay, yeah, because I think you mentioned that you changed the reporting from, you didn't go monthly, you did go quarterly because you felt that that was probably more accurate. And then there's another question. In developing this report, did you take into consideration that SHIA checks the quality of the submissions with the hospitals twice a year before including them in the case mix databases? So only because I work here, and then Ian has brought that up, I am aware of that. So, but I would imagine you guys are aware of that. So I'm not sure how you would answer that question.
No, I think that's what I'm saying. Really, I think there's a thing the hospital checks. I think there's a hospital checks during the year. So sometimes the issues we're finding that before we reporting out like issues like the stay, we're finding it like even beyond like the reporting period for the submission period. So how to handle data that is maybe potentially more historic that we still have to consider, and especially like when looking at when trend pre-pandemic length of stay before the start of the pandemic, and how was ED length of stay increasing, and then how potentially did COVID impact length of stay, to make sure we have the best data certain time periods, so we can make historical comparisons.
Okay, that makes sense. And we have another comment from Sylvia. She's clarifying that length of stay in the ED is calculated in hours, which we know is it's the count of hours between registration and discharge time. I think she's just trying to help us out with that. So let me see if there's any other questions. You guys did a great job. We don't see any other questions. So let me see if I have anything else. What about, and I think you already spoke to this, but systematic issues in reporting length of stay? Like some hospitals, I think you already stated, I was wondering, are better than others. And I don't know if you want to add anything to that, the variation among hospitals, or if there's anything you want to say.
Yeah, I think just going into more detail, there are some hospitals that have some off hospital quarters or months, and it's more at a random level, which is why we check this more thoroughly. We don't kind of expect that like a certain hospital cohort or a specific hospital characteristic would necessarily have these kinds of issues, but this is why we check them thoroughly.
Excellent. Okay, well, I think that's all that we have for this, and I just want to thank all these presenters here and for the whole conference, because I've been inspired for a couple days now, and we're at the closing plenary. So thank you all for hanging on this late in the day, and I will hand it back to Norm to give the closing of this session. Thank you.
Thank you, Betty. We do have one last item of business. We've got to do our final prize drawing. I'm going to take care of that right now. And our winner is Kyra Morgan from Nevada. So I'm very, very pleased to announce that Kyra's won a $250 Amazon gift card, and thank everyone, 100 and some odd people who participated in our token hunt game. And we're thankful for all of you for participating in that. One last thing as before we go, this has been fabulous, but we do look forward to seeing you in person in New Orleans in May. So there's the dates. Make sure that you put that on your calendars. Don't schedule any family things during that week unless they're in New Orleans. We'd love to see you. And it's going to be a great opportunity for us to network and to get together and celebrate and discuss what's going on in our world. So with that, I'm going to officially conclude our 38th annual conference. Thanks to all of our organizers, all of our presenters, the planning committee, the board, and especially to the moderators and presenters who made this possible. We couldn't have done it literally without you, and it's been fabulous to have all of this great content here. For everyone's information, all of the sessions have been recorded, and we are uploading the last 2 or 3, but they should all be available for you for up to 90 days in this platform. You can come back and watch them and get information if you miss somebody's contact information, or if you missed an entire presentation, they will be here for you. So with that, thank you, and we will see you in New Orleans in May. Thank you, everyone.